fruit.
لأنه العالم سافرت ولا؟
في كله.
ما أعتقد. So,
Let's start.
but where is the?
Yeah, we can start.
But are you muted?
You can, no, not muted.
They heard us. So you want to do introduction?
So we have the pleasure tonight to have Dr. Palermo. No need for introduction. He's the pioneer of ICSI, the one who started. We'd like to know the secret, how it happened. And we have the chance also to have Rony Elias with us from Cornell, New York. So, Dr. Palermo, the floor is yours.
Oh, thank you. Well, thank you, Dr. Abou-Jadeh and Dr. Elias for involving me in this. Maybe I'm going to share my screen. I'm going to figure out this. So, okay. Oh, I think you have to allow me to share the screen.
1 second.
1 second, Gianpiero.
Sure.
Thank you. Okay, you can go ahead.
I have to put it. Yeah, now you can take the screen. Yes.
Okay. I think we. Can you see it? Okay.
Yes.
Okay, great. So I was asked by you guys, to give some update in IVF laboratory. Really, for the ICSI laboratory, that's what my team and I are good at, especially taking care of your patient or your type of patient, very, very sophisticated. So I would like to, let's see if I can, yes. So I think it is important to consider that the spermatozoa has its own DNA, is highly packed. In this drawing, you can see that there are certain areas of the spermatozoa that are highly compacted around the protamine core. And there are certain areas that are linker region where residual histone are there. These are very weak areas that undergo a certain damage and that we assess with the sperm chromatin fragmentation assay. So, and the solution has been proposed by the urologist to perform surgical retrieve specimen. So we actually performed this study in patient. Okay, where we have at least 38% of chromatin fragmentation, depend sperm chromatin structural assay or bitano in the ejaculate. And then this work has been done together with Dr. Goldstein, our reproductive urologist. When you got into the vas deferens, you have about 17 to 23% of DNA fragmentation, and the epididymis is lower to 15 to 16%. Please note that our threshold for normalcy is 15%, so it's just there borderline, and in the testicle became normal. And that's what has been suggested in this particular study, just shy of 50 patients, where we have a fertilization of 66%. This was published on the American Journal of Urology in 2020. You can see here the implantation was only 3%, with a clinical pregnancy 6%, a very few deliveries. So if we use surgical retrieved spermatozoa, although we maintain a fertilization rate about 60%, we have an implantation of 13%, a clinical pregnancy of 30%, and a delivery rate of 22%. So of course, there are patients that are not really very eager, consider that they have normal spermatogenesis, to undergo surgical sperm retrieval just to correct the DNA fragmentation. So in 2014, we wrote a paper on fertility and sterility. It was entitled Perspective on Sperm Chromatin Fragmentation. And the most important message of that paper was that there is an inverse relationship between the DNA fragmentation and the progressive motility of the spermatozoa. Therefore, we've looked into alternative, and this is a microfluidic chamber. They're different type, but that's what we use. The 800 microliter chamber is known as a Zymote, and is so we did some study here in 70 patients. We compared the raw specimen with density gradient and microfluidic. You can see here that well, the volume reduced, obviously. The concentration also reduced from 28 million by density gradient, 17 million, and 8 million with microfluidic. But the motility increased dramatically on the raw specimen from 33% to 97% and higher. Even the morphology increased somewhat significantly, so to get almost normal, close to 4%. So when we look at the motility here, this is the raw specimen, this is the macular chamber. You see that there are few motile spermatozoa. Then if you perform a density gradient, there are more motile spermatozoa, and the sample is clearly cleaner. But if you perform microfluidic, you see that it's close to 100% in very, very clean specimen with very low DNA fragmentation. And indeed, if you look at the raw sample here by tunnel assay, you see the 26%, the sperm chromatin fragmentation rate. It decreased to 18% with density gradient, still above the threshold of 15, but with microfluidic, it barely 2%. So that's very reassuring. This is the first study we did together with Alessandra Parella in my team and Olena Coker more recently, one in Yarge, one in fertility and sterility. You see on 80 patients overall, you have 191 cycles this patient did. You see the demographic, 37 years of age, the maternal, so, and the paternal, so quite, you know, borderline patient, so quite advanced, the maternal age, I would say. So the fertilization rate was 66%. And when we do microfluidic, we have done 90 cycles. These are the same patient. They failed the initial cycle with density gradient, so they came again. So the age match, and the fertilization rate is pretty much similar. But when you look at the index cycle with the density gradient, you see that the implantation was 8%, 17% clinical pregnancy rate. When I say clinical pregnancy rate, I say the presence of at least one fetal heartbeat, a 7% delivery with very high incidence of pregnancy loss. So for those that didn't get pregnant, they come back later with us, and you can see that the implantation rate increased to 23%, the clinical pregnancy to 41%, similar 36% delivery rate, a very minute pregnancy loss. So then we came across to another paper, and this was very interesting, 2019, and this from Casanova. They actually indicate that not all the DNA fragmentation is the same. There is a total DNA fragmentation, more specifically the single strand and the double strand. So they consider that the double strand is the most relevant in terms of pregnancy outcome, in terms of the ability to have a successful delivery, and the fact that this double strand actually may be linked to structural chromosomal abnormality. So while we thought that the sperm chromatin fragmentation is just related to certain aspect of the epigenetic of the DNA, with this double strand, we can actually link to the aneuploidy, and that's very intriguing indeed. So we did another study. We did a COMET assay we apply in our laboratory. This is a neutral COMET assay specific of the double-stranded DNA break. So if we look at the result here, I show you this table before, but if we, in the same patient, we treat them, we test them by COMET assay, we see the double-stranded DNA break is minute, but still relevant in the raw sample of 3.6%. By density gradient is mainly unchanged. But if we perform microfluidic, became almost negligible, 0.3%. So we did another set of patients, and even the patient of Rony are included in this study. It's an 85 couple, and if you have 88 cycle history cycle, with a fertilization rate of 66%. The age is similar, 86 cycle by microfluidic. The fertilization rate improved dramatically to 78%. And you can see when we look at the euploidy of the embryo in the density gradient cycles, the euploidy rate is barely 25%. But with microfluidic, we almost doubled this to 43%. So we thought this was very encouraging. So, well, this is the history cycle. You see implantation of 6%, clinical pregnancy 10%, no delivery at all end up in pregnancy loss. But if we do the same couple with processed by microfluidic, we got an implantation of 65%, a clinical pregnancy rate very comparable, and the same 62% delivery rate with almost no pregnancy loss. So now I'm going to speak to you about our more recent paper. These have been highly requested. And this is a non-randomized clinical trial to assess the safety and efficacy of sperm sex selection. Certain people, certain countries are very prone to this study, so we're going to share with you. So this is the study. We use couple that have enormous semen parameters. You see the concentration, motility, and morphology close to 4%. We use this home device, proprietary density gradient system. And you see that when we are able to enrich for the X-bearing spermatozoa to 82% and the Y-bearing spermatozoa to 81%. So when you look at the number of couples here, 52 couples in 70 cycles, you see the maternal age is quite, mature, 38%, 39 years of age, and the paternal age, 42. So the couple with the embryo, with the female embryo that they actually wish, is 83%. So we were able to project the enrichment of the spermatozoa into the embryo of the desired sex. So by doing so, is our idea, although the sex selection is quite controversial, especially in Europe, but we think that by doing so, we reduce the number of embryos that the couple end up wasting, because if they want a boy or a girl, we enrich the embryo to have the gender that they want, so we reduce the wastage of the embryo unwanted. So for the embryo transfer cycle we've done so far, 29, we have a clinical pregnancy rate of 62%. This obviously, we transfer a euploid embryo of the desired gender. So the delivery rate match 52% here. So you see the results are very similar to what we get for cases with PGTA. And that's explain why we do this test, because of the maternal age. If we select for male, 45, 46 couple in 50 cycle, a little bit younger, 37 years of age, the maternal age. You see the couple with male embryo, also 87%. So the large majority of the couple get the same proportion of enrichment that we can get for the male embryo. So for the transfer done so far, that's describing in the manuscript, are 21 frozen embryo transfer cycle with the euploid embryo of the desired sex. We got a clinical pregnancy rate of 67% with the corresponding delivery rate for the patient is still ongoing. So this is a clinical trial nationwide, so it's registered. We also share with you something very, very new. We wanted to complete the 20% that we are not able to select. So we are successful at 80%. We would like to go toward a 90 or even higher. So we work with Dr. Jackson Kierman Brown from Birmingham in the UK, and he came over and actually was able to assess the spermatozoa selected by our technique. And he's able to identify certain wave motion of the tail or the flagellum for male that you can see they're much wider, more fluent, I would say, the motion. So we think we're positive that we will be able to actually distinguish the spermatozoa post-selection that are actually male or female. Because as you see, we selected by this sophisticated density gradient, but at the end of the day, we are going to pick up one sperm by our own criteria for injection. So if at the time of injection, we are able to display the characteristic of motion of the spermatozoa that we select by a complex computational mathematical algorithm, which should be able to identify specifically the spermatozoa desired. So I just want to thank everybody on the team here at Cornell that helped me out to put together this talk. Thank you.
Thank you, Gianpiero. I don't know if the group have any question before I do my part.
Yes, we have a lot of questions. First of all,
let me stop to share. Yeah, okay, I see you again.
Yes.
You have time, Gianpiero, right? I know you have you in 30
Yeah,
minutes.
I moved my patient from 10 to 11 for you guys.
But I don't know
didn't
if you
realize.
know, there are 23 retrieval today, so you're gonna be running across the store.
Yes, yeah,
very
we have a
soon.
few things. We have a few things.
Yeah.
I want to ask you,
Please.
actually, did you find a place for zygote and testicular biopsy? You think it's comparable? What is better? Because there is no comparative study until now.
No, there is no comparative side, but I went to the American Society of Andrology meeting, and many scientists, they're told that they stop using testicular sperm for high DNA fragmentation. So I would be, I think it's an indication that you have to have a patient with a lot of sperm, because when it starts to be really a poor specimen, you may not be able to find match. So far, most of the time, we found normal DNA fragmentation in the testing, but not 100%. So you end up putting a patient with a surgical risk, with the anesthesia risk, the cost of it, and obviously the emotional distress for the patient, and you may not have normal spermatozoa, because all the time we do this study, we actually assess the tunnel on the testicular specimen before freezing. So the urologists know which side to use, because sometimes the left side is bad, the right side is good. So it's very inconsistent. And you see the pregnancy rate, you see in our study, we show surgically retrieved spermatozoa, but the best pregnancy outcome we got with epididymal. And most of the time, the epididymal is borderline or abnormal, because the testicular spermatozoa, as you know, fertilize less well than the ejaculated. You see, with ejaculated, we get 80% fertilization rate. With testicular, if optimal, you get 50%. So you have to consider also how many eggs you're going to get, etc. So zygote win. And also, what's the loss in trying one cycle of zygote?
There is another technique comparable like zygote. It's a microfluid, the G-prep preparation, very simple technique, cheaper than zygote. Did you have any experience of that?
No, I know there are different methods, but the point is, it was Jim Mariano from Canada. I was at another meeting in Canada in April, and they just completed a study when they did just swim up and zygote, because zygote really select the most motile spermatozoa. If you do a swim up technique, a good swim up technique, and you have enough sperm, you should get the same motility rate of 100%. However, they saw that zygote was able to reduce the chromatin fragmentation more than the swim up. So, but that contest, I would be skeptic unless there are data that they assess the chromatin fragmentation. I don't feel comfortable to give a specific answer.
For the next second talk, we have in Middle East the big demand to have a male gender selection. So I don't know in USA if the demand is so clear, like in the Middle East.
I wouldn't say it's for male, but there is demand for gender selection. But it's not more heavy towards male versus female. It's more for family balancing.
In New York, there is more, I noticed, a wish for female in New York City. Patient of New York City like female. But independent, that's a very personal, I would say, like Rony mentioned, is very, very personal, mostly for family balancing, because they have 2 or 3 girls and they want a boy, vice versa. The issue is we do more and more than us, other center, they do PGT, the blastocyst culture and then PGTA. So the patient end up knowing the gender. So, and then they want to, they end up selecting. The problem is they end up 50-50 most of the time. So they end up spoiling the gender that they are not interested in, because they end up donating that embryo, etc. So we propose with this technique to reduce the embryo, the unwanted embryo, let's put it away.
Anyone have any question to ask to Dr. Palermo?
So Gianpiero, I don't know if you're gonna, I think you have a few more minutes. So because I'm gonna be presenting a few cases, but the first few one are mostly.
I'll try to stay if it's okay with you until I can, and then I think at the quarter to 11. Yeah, sure, I'll listen. Yeah.
Yeah, just because
always to learn. Always to learn.
We're all learning. Well, because the first few cases are, I put the interesting male cases first. So, and I'm sure you probably remember some of these. So,
Sure.
First, let me thank everybody for logging in tonight.
Maybe I could say one thing. I think it's very important.
Yeah.
I have to acknowledge that Dr. Elias is a fantastic teammate, because you can do new things in the laboratory, but you have to have a physician that understands what you're going through, and you're doing your best to try to help the patient. So he is always very prompt to let us try something new on his patient. He's extremely open-minded, and that's admirable of him. I like to share, because I know you are from his own country, and I think you should know this. He's an extraordinary individual, because he's very open to innovation, new things, and very understanding, and very kind to the laboratory team.
Thank you. I'm as good as you know. So thank you, though. Like, I cannot be better than the embryologist. Any REI is as good as his embryologist. And in your case, obviously, needless. You don't need an introduction. Everybody know who they are. I'm gonna start by sharing my screen, which is hopefully this one. I hope everybody could see it. And let me. How do I have to move the slides? Okay. Can we move this to the side? Okay. Okay. So again, thank you everybody for logging in. My name is Rony Elias. I was very fortunate to go to AUB, which opened so many doors for me in the States, and ultimately ended up at Cornell, where obviously I have the honor and the privilege to working with Dr. Palermo, Dr. Rosenbach, Dr. Peter Schlegel. Anybody who's very well versed in the field will know who these names are. And I'm extremely fortunate for their continuous support and sorry. They never taught me how to use an Apple, so I'm sorry. So that's it. Let me actually go one more up. Okay, got it. So, obviously I have nothing to disclose in relation to this talk, but first, I'm just gonna, I spoken to Imad, Dr. Abu Jawdi before, just asking what will be something interesting to keep everybody a little bit, what I could maybe add to this, and hopefully also myself learn. And he suggested to just first go over some baseline recommended testing that we do at the Center of Reproductive Medicine. And having Dr. Palermo available, I figure I present some of the really challenging severe male factor cases, couple of cases that include microfluidics. And interesting enough, I wanna, knowing who Palermo is and how he's like the original ICSI guy, how he doesn't necessarily recommend. Sorry, I'm gonna have to mute somebody. 1 second. Okay. So I want to basically point out to the fact, as he mentioned, maybe I am open-minded, but he might be even the one who taught me this, because as much as he's the ICSI guy, very interesting case that he actually recommended for me not to do ICSI, and hopefully this will be a teaching point, not just for that case, but across multiple other cases. And then the last few, I will talk about some really severe premature ovarian insufficiency, as well as what he slightly alluded to, that we don't do pre-implantation genetic testing for aneuploidy on everybody. Cornell is actually the first center that did PGTM, which wasn't called PGTM at the time for sickle cell patient. This is, I think, 95 or so. I mean, Palermo would know more. But so we're very experienced in that, but we don't do it for everybody. And hopefully the case that I will show you why one size doesn't fit all. Not going on. Okay. So as we all know, I mean, definition of infertility scientifically is very different than the way it's practiced, at least in many countries, which is here. Unfortunately, the pressure of the mom and the mother-in-law is to have a baby in 2 or 3 months after you get married. And if not, you have infertility. Obviously, we all know that it's not the case. It should be 12 to 12 months of regular intercourse and more than 35 years. If you're more than 35, they recommend that at least you evaluate the patient after 6 months, despite this not being called like infertility yet. And if more than 40, consider immediate referral to an IVF doctor. So the main reason, as we all know, is the advanced maternal age. I'm gonna, not necessarily go over all of these in detail, but I wanna show you, this is Cornell data. This is pregnancy outcome. Look at this is 1995 to 2005, many years ago. But I hope you remember this later in the talk to tell you why that is kind of relevant. Because I do have the earlier data. If you look at the clinical pregnancy, which shows defined as positive heartbeat per transfer, you're talking somewhere in the again, this is per transfer. So those patients went through cycle and had a transfer. Obviously, 95 to 2005, the rate of PGT-A was much less than now, but you still had a 17%, 23%, 31%, etc. Even if this kind of older age group, you had a 54, 53 in an ongoing pregnancy at the younger age group. And as we all know, the main reason for that is because every woman is born with around 1.2 million. She had 6 to 7 million when her mom was pregnant with her, and then there is a rapid decline that starts to actually might be a little bit deeper here at 37 or so, and then when you get to 50 or so, 51, there's around 1,000 eggs left in place, but those unfortunately do nothing. And PGTA, this is obviously how it's done for the embryology team, was able to give us more input into that. This is when they did PGTA. This was the group at RMA in Jersey, across the bridge from us. They did 15,000 biopsy, and they noted that at 43, they were still able to get 16.6% of normal embryo. Practicing across from them, knowing the kind of patient, almost all of these were excellent, responded to qualify for that. They had very good AMHs. So those are people who are not your average 43 years old. So 16%, they had blast formation much more than the average person because they had a very high absolute number of eggs to start with. They're not somebody who get 4 or 5 eggs like the average 43 years old. On the other hand, our data is kind of quite different. At 43, we had around 7.6% normal one. And this is based on more than 12,700 embryo. And my point in all of that is that once you start to select for patient to do PGTA on everybody, you're going to be excluding a lot of those patients that will probably might have been pregnant and have a life birth of healthy child despite them being older. And I'll come back to this later in my talk. So what do we do? Obviously, talking to the patient, classical medical student, teaching point, always listen to the patient. She probably will tell you, or he will tell you what it's wrong with them. Any prior treatment. Most of the time we spend like reviewing prior stimulation, no matter where they were done. We could spend hours sometime, 6, 7, 8 IVF cycle done somewhere else, no matter where those places done, in the country, another country, because those tells you much more than her AMH, much more than her ultrasound, much more than anything if somebody had went through an IVF cycle before. Pregnancy history, menstrual history is important, quarter frequency, any past surgery, pelvic infection, and any lifestyle, especially as it relates to smoking and drug use. We all probably under the pressure from the patient to basically, what can I do? Unfortunately, there is not much that we believe that the patient can do other than being seen at younger age or freezing eggs at younger age. To my knowledge, there is none of those, whether it's CoQ10, DHEA, you name it. We looked at all of these. There's nothing that showed a difference. Growth hormone, testosterone, those actually, there is some evidence around them, but as a lifestyle, most of these really, it just, you put more stress on the patient, making her feel like she's responsible for a bad outcome, where actually it's age. The one thing that we know is smoking, and that's the big no. But everything else, being caffeine, special diet, Mediterranean diet, gluten-free, all of that, this makes no difference. Now, in addition, obviously the history, we ask everybody to do a sperm test, even in the presence of prior pregnancy, even for secondary infertility. I would say maybe twice a year, we have a couple who we find that the male is azoospermic, and he's not like obstructive, he's a non-obstructive azoospermic. So obviously that's a long discussion, that's a big discussion to make with the couple, how she was able to conceive. But you always know who the mom is, you don't necessarily always know who the dad is. The regular cycle, history of regular cycle, any anatomical problem, and I'm gonna stress this tubal patency to the rest of the talk. This is super, super important, and hopefully you guys will get the point later on, and any peritoneal factor. Now, male factor is believed to be as the only reason in 20% of the case, but 30-40% could be both of them. So the fact that you find that the male has a problem doesn't mean that she's fine, and vice versa. Could be combined, it could be just him, it could be just her. And again, prior pregnancy doesn't guarantee that you have normal sperm parameters. Things could change, not as drastically as the female, but they can change. And here, as we all know, that 2010, the WHO changed the cutoff, the criteria, down to 15 million. And as you probably all know, for the last 60 years, there's been a drop in the sperm number in human. But obviously, fertility is still, relatively speaking, like we're not going extinct, but at the same time, the absolute number are getting less and less. But the concentration was dropped from 20 million to 15 million. That was a big one. And obviously, any male factor, the first thing you want to do, we always refer to urologists when it's a severe male factor, because you don't want the testicle to fail when it comes to the hormonal production. Even if somebody has a 1 million sperm and they do ICSI and they probably will have their family there, we shouldn't ignore there could be something else wrong with the testicle. You don't want them to have failed testicular function at a young age. And now, needless to introduce ICSI, we all know about it now. So this is the first case. So this case, those were all real. This is my patient, basically. 33 years old, never been pregnant, had a severe male factor, had failed TESI and biopsy once before. She had one motile sperm in the ejaculate, had done more than 4 to 5 cycles, had anywhere from 6 to 11 eggs. Those are all prior to coming to us. Some she even had a transfer and a negative cycle. Everything was negative. The male karyotype was normal. Despite her young age, despite the problem at 33 years old, you always think like, why you're here, right? Why she's here? She's here because of her partner. She's not here because of her age. That being said, the prior treatment involved her doing PGTA. They did it at the time, I don't know, it was from another country. They did it on day 3, and she had 2 abnormal embryos. So now the patient was told to believe that she has a problem with her in addition to her husband. Oh, you don't make normal embryo. So I saw her. We do the classic female and male panel, which involve regular blood tests, CBC, hepatitis B, HIV, syphilis, thyroid, prolactin, etc. We do AMHs on everybody. We like to see them every 4 to 6 months. She had a saline infusion ultrasound that was done outside. We always require the sounding. I don't know if you call it sounding here. So sounding is basically it's a trial transfer. It's basically a mock transfer. We do it way before, because some of our patients would need anesthesia. Most of them don't. Maybe 50-60% will need to be ultrasound guided. We don't do ultrasound guided, especially if it's retroverted. So we like to map it out before. We have to, we prepare before we do that. No matter like between children, and we have to do this with us. We do. In those cases, every single one of them asks them to do extensive sperm tests at our center, and if they find any sperm, to freeze it. And we refer them to Dr. Schlegel, who's our reproductive urologist, for microtesting as a backup. So in her case, she's 33. She had a relatively low AMH, 0.7 nanogram. Her weight she's on the 55 kilogram. So I'm not sure if the group is familiar with E2 priming. People used to call it the Cornell protocol, but people call it E2 priming now because many other centers use it. But it's an estrogen. We can talk about this later because you're not familiar with it, but it's an estrogen suppression a few days before the start of the cycle. And we gave her a total of 300 units, 225. This was the plan. And then antagonist. And that's, I think, where we differ relative to here or Europe, as well as few other centers. We tend to see people quite often during the cycle. So this was only for 2 days. We gave her this only for 2 days, and we came back we brought her back 2 days later to check the blood. And this was all pending what her FSH on the day of start and her ultrasound are. And I don't know if you guys, is it blurry? Maybe I could explain it. So this is what we did. I did 225, 150, saw her 2 days later. Her estrogen went up from 20 to 170. We don't like that. And that's actually why we like to see people early. So we start to drop her here to 200, 150. She almost a little bit less than doubled here. Started the antagonist. We like to start the antagonist around estrogen of 300 or a follicle of 13 millimeter. We might be starting it too early some other places, but we are on the side of doing it earlier. I could explain why, the reasoning later. And then saw her that day. She was around 12 and a half. And from this point on, we start to see her every day. Now, between parentheses, I want to mention this because I spoke about this many years ago to somewhere, I think it was the Middle East Fertility Society. We have a global fee for all of this. So whether we see the patient 1 day or 10 days, the quote unquote charge is identical. This is way more extra work for us at no extra benefit, financial benefit to the center, not to the physician. We still tend to see very rarely, maybe 5% of the case, we see patient twice a day. We see her in the morning, we see a southern follicle size, we get the blood at noon or early afternoon. We're not sure if the trigger is that day or the day after. We wait for them to like 5 or so, 6 even sometimes to come back to repeat the ultrasound. Many patients hate it, but at the end of the day, they appreciate it because now they're coming to the doctor twice. Besides figuring out the right size to trigger, which we strongly believe in, this has, like there is no other benefit into that. So she get 12 eggs, not very mature, and 1 fertilized. I'm sorry you guys cannot see that. Now, this one, we had used testicular sperm because he didn't have sperm in the ejaculate. We did TESI, micro TESI, they found sperm. We did testicular sperm, only 1 developed. The embryo didn't develop. The embryo on day 3 was 2 cells and 5% fragment, canceled the transfer, did nothing. Brought her back. Now she's older. I think I forgot where she was. I forgot actually. Then she went back home, then came back a few months later. Give her a little bit more drug because now I was more comfortable knowing what she did. Now, 225, 150 unit of Menopur, 225 Fostem. Same thing, saw her 2 days later, estrogen here didn't double, follow-up, etc. Give her the trigger shot at 17 to 18 millimeter. So relatively, and I almost always do dual trigger, which involve Lupron and ACG. In this case, we actually, Dr. Palermo was able to see sperm in the ejaculate. This say ejaculate here. Very, very few sperm. It's a shame you guys can see that, but this say that, they did oocyte activation here, and I'll defer to him if you guys want to know more about it. But he did oocyte activation for her. She did fertilize 1, 2, 3 embryos. This is not TESI, this is ejaculate sperm with oocyte activation. The patient had 2 embryo transfer, 1 8 cell, 1 6 cells on day 3. And I can talk to you more about this, but we use time lapse on everybody. And she had combined here around 38% chance, 22% implantation on day 3, 16 on day 3. And then the grade was over 5. So 1 being the best, 5 is the worst. This is day 3. She had a 2 and 3.5. She ended up having a full-term baby girl with a ejaculate sperm. The major difference, slight change in the protocol, but more importantly, did oocyte activation on her. Now, the second case is, this is somebody who had went through 2 miscarriages, very young patient, severe male factor, had done 5 IVF cycle, had a 1 miscarriage at 5 weeks, 1 IUFD at 5 months. No prior surgical history. She was at UAE before, 16 eggs, 11 M2, 9 ferts. Again, they do PGTS, by the time called PGS. On day 3, everything was abnormal. When the ultrasound done, it showed that she had pretty good intrafollicle count. She had a right dominant side with multiple follicles, but the left was not easily seen. No surgical history, the left not easily seen. Now the plan, we did the typical workup. We do in addition to her 2 miscarriages. Well, this one might not qualify, but we still did the recurrent pregnancy log, which involve only 4 things that we do. We do lupus anticoagulum, beta-2 glycoprotein, anti-cadulipin antibody, and we do the anti-thyroid antibody. And obviously the parental karyotype. We did extensive sperm with freeze and HSG, saline infusion, and the sounding again. So we perform our own HSG. I don't know if you guys do them here or radiologists do them. We perform them ourselves. Most 95% of the center send them to the radiologist. They get a report it's normal or not. And I can't stress how important for at least for the fertility doctor REI to look at the images. So if you look here in her, you don't really see much stuff here, no filling. The right side did fill here, but not much filling. But my read was right fill, minimal fill, left mid-segment fill. This is mean. And we still, for insurance purposes, because the insurance pays the radiologist, not us, He mentioned normal fill of the right tube without evidence of spill, very consistent, abnormal termination. So very similar, at least in this case. Now she had a pretty good image. This is nanogram per ml. I think you guys use that, or picomole, I'm not sure. Her workup was negative. I told her, in your case, your main issue is your partner. Not sure why at 30 years old you're doing PGTA. You can still do it. She insisted on doing it because she had multiple people telling her problem is viewed, etc. We went ahead and did it. I didn't give her, relatively speaking, a lot of drugs, 150, 75. She still ended up with the estrogen of 3,000. You can notice here, this was one of the fellow, basically. She mentioned that they saw something. There was nothing really seen on the left. Still with that, she got 16 eggs, 12 mature, 10 fertilized. Insisted on do PGTA. Now we did ejaculate here. Did ejaculate. Embryos looked okay, actually, some of them on day 3. And then when it comes to PGTA, she has 4 that were frozen on day 6, came back, every single one abnormal. And now the patient is more convinced that she has a problem with her embryos. It is the sperm, is it the egg, is it the poor sperm? Shall I, in her religion, in her religion, she would never do donor sperm nor donor egg, but she still wanted to cycle again. So I told her, this doesn't make sense to me. I think PGTA is overreading this, or there could be something in the, let's do another cycle. Very similar, since she got plenty of eggs, almost identical protocol, 18 eggs, 13 mature, 8 fertilized with ICSI, only end up having 2 make it to blast. Nothing is normal. So we discussed it with Dr. Palermo, and we were like, okay, how about if we they don't do sperm donor, but they're willing to do it for research purposes. There's a good number of eggs. So what we discussed is, how about we split it? We split the egg into or 430, etc., and we do microfluidic. This is when microfluidic was starting to being more applied. We did microfluidic. We split the egg. You can see here, husband ejaculate. We didn't fully split them. We gave more percentage to the husband, and this is the donor. And she actually had 3 normal ones. So in both group, she had, I think, 2 from the donor, 1 from the husband. You can see them here. This is the one from the donor, from the husband, but she went from having 0% normal to having 3% normal. She's like, okay, I don't want to have just one shot. Let's do another one. I had incorporated Clomid here, because in the cycle before, we tried to do something different, and we incorporated Clomid into the protocol. She still did 17 eggs and 14 mature. Now she had 17 frozen, did microfluidics, no donor anymore. We're done with donor. We went to fresh, and then to partner. She had more blastocysts, and she had 4 normal out of 7 and 1 mosaic. Okay. This was Clomid and injectable. We almost never do Clomid. This is Clomid and 150 and 75, 150. This is identical to the cycle before. And now she has 5 embryo. She's like, okay, I'm ready to have a transfer. So we did the first transfer. This is the PGTA. This is the biopsy. Our embryologist here in the audience would know that that's where the biopsy side, actually 6 VB embryo, like not a bad embryo. Our embryologists were trained by Dr. Lucinda Vick, and maybe the embryologists know who she was. She was very, very strict. So most of the time, this would I don't know, what would you call that embryo? I don't know if you can see it. Would you grade it as the same as BB? Yeah, okay. Because usually we were told that they're typically very strict with their criteria. Like some people might call this as higher, basically, or A-. They do A-, B-, C-, which drive us and the patient crazy, but they were trained by her. Anyway, we do this one, PGTA normal, on somebody who was able to achieve a 5 months pregnancy. So expectation were high, and then nothing. She doesn't get pregnant, negative cycle. I was like, you know what? Your IUFD, you had a DNE. I don't like the way your HSG look. This doesn't make much sense. Let's look, maybe there is something else. And she agreed to do a laparoscopy. And to my not big surprise, she had a torsion at one time, never had surgery. This is a virgin belly. This is her tube. This is her left tube. This is the one that we couldn't see. She had had a torsion at one left, completely lost that left ovary. That's why we were not seeing anything, and also had a small hydro in it. So endosalpingosis and focal. This is the actual path report. First cycle after that, have a full-term baby. Came back this was 2017. Came back very recently in November 2022. I repeated the HSG. It was like maybe something developed due to pregnancy in the other one. The repeat was fine. There was nothing on the right side. We proceeded with a frozen transfer. Keep in mind, we always transfer the best embryo in. So the best one that went in gave her nothing. The second best one gave her a GERD, and the third best one gave her another. I mean, she's due in August 14th. So we gave her, she's passed now. She's discharged. She's with the OB now. So the point of the story is, I don't know if Dr. Palermo is here, but basically still here, is about, how the microfluidics did make a difference. The donor sperm did not. This is somebody that could have done donor sperm as many times as she wanted. She probably would ultimately get pregnant, but maybe miscarried or not because of the likely tubal disease. But she didn't need to do that, and she has a baby with her partner. Gianpiero, are you still here? Or you had to go? I think he had to go. Right? Yeah, I think he's not here anymore. Yeah, he had to go. So this will be the second part of the second part of my talk. So
this case, you remove the small part of the left tube
that had salpingosis in this.
The small part, and you believe that this was the failure.
I mean, this is one. I mean, we have hundreds of patients now, but that's one patient. To be scientific, this is a one patient case. But my point is not her outcome. My point is that tube had salpingitis in it. Like on pathology.
Yes, like
so
that's like small hydrosalpingosis.
Yeah, it did have a small hydrosalpin. So it does affect. It cuts down the chances by 50%. Because for me, I couldn't blame the embryo anymore when we put it. Now, obviously, not every normal embryo is going to give you a baby, but she should still have probably in the 60+%, knowing that the embryo is normal and she had achieved the 5 months pregnancy. It's not somebody did it develop. At what time, all of that, I don't know. She had a virgin belly. I don't know. Nobody's been there before. So this one is basically, when do you do ICSI, when you don't do ICSI? That's actually was a very interesting case that actually we presented her at a few of the meetings, including recently we had a group that came to Cornell. They wanted to present interest from UCSF, another big center on the West Coast, and they presented this to them. So this is a 29-year-old. She has a regular cycle, trying to conceive for 10 years. She was status post 15 IVF cycle before, 15. Low response, and almost every single one had immature egg. Actually, I think most of them, like 90+%. She had some cycle that had transfer with poor embryo. Everything was negative. This one, she had a prior surgery before. She had a laparoscopy, she had a hysteroscopy. No prior sperm test, but she had sperm analysis during the IVF cycle, so that's fine. Her image had fluctuated, different lab, different clinic, different everything, 0.9 to 2. No prior HSG. Now, on my initial exam, the minute I do the ultrasound, I see she has a low follicle count. Same thing. I see that she has a small, like something on the left side that doesn't look right, maybe a left hydro. And we did her karyotype and view of her immature egg, normal. The HSG didn't show on the left side, no fill or spill. So we counsel her about similar story. Let's do an IVF cycle, but she wanted to do a laparoscopy first. We do a laparoscopy, not a bad tube. You see a little bit of endometriosis, but look on the left side, open chromotubation. Something was noticed here. And the right side, on the flip side, was okay, but the left side clearly had a problem. So we removed that side, and then fallopian tube was mined hydrosalpinx. Now, in her case, obviously, she had very bad egg, very poor embryo. I couldn't really explain the failed pregnancy due to that, but if she was going to ever have a good embryo, I didn't want anything to affect it. But her main issue is her egg quality. Did the first cycle with us, 8 eggs, 1 mature. Her follicle size was 17, 20s. And this one, it was fertilized. This was one was degenerative. The immature, we do sometimes IVM, we do in vitro maturation. One of them matured, but it didn't. The next day they fertilized it. It didn't fertilize. And the one that developed was only 4 cells, was poor, grade 3, 6 cells in the afternoon. We transferred it, nothing. So we did another cycle, and this one I changed it to microdose Lupron just to kind of change things out. We did the cloma, the first one, and with that, she actually, by the way, had tried to start a few times here, but she either have a cyst or high FSH or something. But this one, I spoke to Palermo, and he was like, "How about we don't do ICSI? How about we just do insemination? Maybe there is." He believed that there is a delay in the maturity of the cytoplasm versus the nucleus, and you judge the maturity from the nucleus. Let the eggs incubate in their own cumulus, and let's do insem, knowing that his sperm is okay, the partner's sperm is okay. We do the retrieval. The head embryologist, not Dr. Palermo, another person, calls me. Why we're not doing? Because we have to specify what we're doing for the embryologists. They don't just do it on their own. Why we're not doing this? Why, like, this, she has a crappy looking eggs. I have to see how they look. I have to, it's like, she had multiple cycles before. She actually had done one even here before, but it was similar with ICSI. She had done, I think, 2 ICSI with us cycle. I want to do that. He's like, you're crazy. I was like, let's just do that. I mean, there's nothing to lose. The patient did 16, 17 cycle at the time. Now, he's like, okay, how about we do 1 ICSI and 2 insem? She had like 3 eggs. With this one, the insem did develop. She had more mature in the insem, did develop 7 cells in the morning, 8 cells in the afternoon, 10% fragment, better grade, grade 2, had a baby, had a life course of it. This was actually cycle number 18 in her life. So the major difference, I don't think the protocol made a difference, but that's the one cycle that we did not do ICSI. We still do more than 90% ICSI, because many other indications we do ICSI for. The TESI patient we do, the PGT-A we do, the older patient we do, etc. But if there is no indication to do something, we shouldn't just do it just because it's better. In her case, it clearly was not better. She had a full-term baby girl. So those were my 2 male factor cases. Maybe we can, if there is any question, we can do some now before I talk about the premature ovarian insufficiency.
Yes,
Yeah.
I have two questions. Why you see the patient morning and afternoon? You don't give any antagonist? I didn't understand.
Yeah, this is very rare. We don't see every patient, but we do have antagonists. The reason we saw her in the afternoon is because she had a 15, 16 millimeter follicle. And we get the blood in the afternoon. And her estrogen yesterday was 1500, and now it's 1600. We don't like it when the estrogen plateau. You might not see, I don't know if you guys do blood here, but we don't like that. So we're worried that we strongly believe in post-maturity of the egg. So we're worried that if by waiting another day, she might get crappy eggs. She'll get more mature eggs, but she might get more crappy eggs. We bring her in the morning to see if this follicle crossed this threshold in the afternoon. If we see that it was 15 in the morning and like maybe 15 and a half, 16 in the afternoon, we just maybe increase the dose or do something for an extra day. But if we see if she's like 17, we trigger her that day. So most of these patients end up coming, we end up triggering, but we like to see her. So it has nothing to this is the last day. We're talking about the trigger shot day or the day before. This is not to start analysis.
You see all the patient twice at the end?
Only when the blood is not consistent. Very rarely. Not very, maybe 2% of the case, 5% of the cases.
How you do the trigger? How you trigger?
We usually depends. We usually do either, if it's microdose Lupron, we do ACG. But if not, we do almost dual trigger. 4 milligram Lupron and sliding scale ACG, depending on the weight and the estrogen. Anywhere from 1500 ACG up to 10,000. So the vial of ACG, it could be diluted down.
How you decide the ACG dose? So
we look at the estrogen level and the BMI. If somebody has BMI, we go high. But if somebody estrogen level is like 2800, we give her 3300 of ACG. So we ask her to inject 1 cc and then 3 cc and mix it with the one vial of HCG and then take one back, or 5,000 or etc. So we tell it down.
And for your Clomid cycle, how you use the Clomid? I didn't understand.
We do 5 days Clomid,
Classic.
and then 100, 2 tablets a day, and day 4, 5, we start the gonadotropin while she's still doing that. So she comes in today. We start Clomid day 2, day 3. Yeah, we start Clomid today on Thursday, Friday, Saturday. Sunday, she's still taking Clomid, but she started the shots. Monday, she takes the last Clomid and she takes the shot, and she comes Tuesday for blood and ultrasound. So 5 days, the last 2 days, you add, and then you follow with gonadotropin.
In which case you use the Clomid?
Usually we do it if somebody had decent response on an antagonist cycle, but we didn't like the way the egg looked, because they grade the eggs separately than the embryos, and obviously if you don't look at the embryo, that's one case. We do it usually if somebody had secondary infertility and had a baby on a Clomid IUI cycle, to try to mimic that. Like she had a baby, you can't do better than that, but you don't want to do only Clomid and get less egg. We do that. We do, who else we do Clomid for? Those are typically, I would say, the biggest two. Just to try something different, that's the biggest one. And the second one, if somebody had a good result to it. But we worry about the lining with Clomid because we still do a lot of fresh transfer. So if the lining was not good, we consider doing letrozole instead, a future cycle. So if somebody on Clomid, it depends on the case. Usually I can show you. We don't go by the number. We go. I will show you. Our embryologist will tell us the percentage of each specific embryo to make it to blastocyst based on the time lapse and the cell number. And that will help us determine if we want to push or not. But also, many times embryologists will tell us they look great, but I tell her she had day 5 at this other center at Hotel Dieu, and they never make it. She never get pregnant. Let's just do day 3. Obviously, if she's doing genetic testing, everybody. We do because we don't do day 3 because we like day 3. We do day 3 because the embryos, some embryos like day 3, and those embryos usually because we're referral. We're the only large academic center in the New York area that do day 3. So by default, we're biased because most patients who are coming to us, they're the one who had failed. Day 5 is great, but we don't see them. They had to get pregnant. By the time they fail, they come to us, and you want to try to do something different, we do day 3. So it's a different patient population. If it's a first comer IVF, most of them do make it to day 5. I mean, since when we started in 2013 with time lapse, we have around 10% better rate, including blastulation rate. So we actually prefer day 5 if the embryo prefers day 5. So we don't commit. Like today, I've been on vacation this week, but I've been talking to few of my patients on day 3 to relay the message to them based on what the embryologist sent me. The embryologist will send me a report at 10 and transfer out, it starts at 2 to tell me accordingly what I should do or not. Personally, I'm biased because I hear what the embryologist say and he loves it. He's a big believer. We did sister oocyte for 6 months in 2013. They split every patient into 2, short of the 42, 43-year-old, which there is, it is what it is. There's almost 10% improvement in better selection as well as pregnancy rate. So that's why we made the commitment. Now we don't have regular incubator except for co-culture, but that's Cornell experience. Other people are getting many people pregnant. No, they check. They don't. We used to make our own media, but now they use the commercial media and they don't change it. They don't change it. But they look on day 3. They review the time lapse data in the morning to decide. This is somebody who's intended to have fresh transfer. Somebody's doing PGTA. It is what it is. But they don't look at them on day 3. But if somebody's considering have fresh, then they look on day 3, and then accordingly will decide. But they don't change the media. Yeah. Does the audience have anybody has any question in regard to that first 2 cases? Can we hear them? Can they talk?
Yes,
actually, yeah. We heard them when we don't want to hear them. Okay. Okay.
You can.
So this is another patient. This is talking about premature. This is a very young, 33 years old, had a history of 1 chemical pregnancy. that she had conceived naturally. She was, at the time when I first saw her, she was having some irregular cycle, but she was still getting few periods a year. She had done more than 5 IVF cycles, 2 to 3 eggs. She had a cycle in Belgium, had 1 egg. She was 32 at the time, had only prior hysteroscopy before. HSG, not sure. She thinks she had one, told abnormal, but I told her this is not gonna matter since you're doing IVF. I hear this all the time. It's not gonna matter, you're gonna do IVF. So I do the testing. Normal karyotype, because we do it when somebody, we don't do karyotype on everybody, but a relatively young patient, premature ovarian insufficiency, we do it. Very important, we check anti-adrenal antibody, make sure she doesn't have like adrenal insufficiency. AMH almost 0. She has an FSH of 74. We repeated, it was 56. So clearly it's very high. Sperm test is normal. I told her about the HSG. She heard about it. It's a difficult test. It's painful. Doesn't want to do it. She wants to do, like, okay, but you know, you might. She's like, okay, I'll do a surgery. She does a laparoscopy, and this is what we find. She had a abnormal tube, and same thing, chronic salpingitis. Now, I went ahead, I did the first cycle. Before doing that, we like to suppress that FSH. Similar, this is probably, I mean, this is the reason why premature ovarian insufficiency POI patients do conceive naturally, 10% or so of them if you put them on the pill. The pill suppress their FSH, they start to ovulate. So we're not gonna convince somebody to take the pill, oral contraceptive pill, when they're looking to conceive. So we typically, I do oral estrogen, estrase 2 milligram daily, and I check their blood and the ultrasound. The blood, because I like to see what if I need to add a patch, estrogen patch, or keep her on the same dose. Most of the time, oral estrase will do it, but chronically. And the ultrasound to interpret to see if there is a follicle before it's too late. We cannot judge it from the blood anymore. I cannot use her blood because she's taking it. So we actually had suppressed her FSH to around 6. I think here it shows 5.95. I was, you know, I had the honor also of being trained by Dr. Suhail Muasher, who's a big believer in this. He does a low dose gonadotropin with a Clomid. I did the Clomid, 150/75, did develop a follicle, get the egg triggered at like around 18 millimeter. The egg was mature. It did fertilize. And unfortunately, she doesn't get pregnant. We transferred one, didn't get pregnant. This was 2017, May 2017. Do another cycle, few months later, same protocol, suppressed her FSH, etc. And this one, she got 2 eggs. One was mature, did not fertilize normally, had a 3 PN fertilization. Obviously, no transfer in this one. Patients from overseas, tried another cycle, no response. Yeah, thank you. No response after so long of so many days of thank you, so many days of shots. Does another cycle in November. Obviously, none of us were getting younger during this time. She's getting frustrated. We're still getting mature egg. Look, we're triggering we believe very strongly in triggering at earlier size. Smaller size, 16, 17, 18 or so, especially if you get a mature egg. Trigger at 16, get 1 egg, 1 mature, did not fertilize normally. Now, left home, came back 2 years later. We were here in November 2017. She comes back 2 years later. Hasn't been having period. Put her on estrogen, drop her FSH, shows up to the office. I see a 14.5 first visit, like here after a few weeks of being on estrogen. Started the antagonist the same night, gave her 225 of minipure. Saw her almost every day. I triggered her a little bit because I wasn't sure if I wanted to see what her estrogen is doing. You know, I wanted to see like a nice rise to know that's a follicle. We trigger her bigger here. This is much bigger than what we do. And we froze her at 2 PN. The reason I froze her at 2 PN, meaning the first day of fertilization, she hadn't had a period for a while. She's been on estrogen for a while. And I don't want to risk it. I wanted to kind of like have a fresh, like fresh lining. Froze her at 2 PN on July 2019, brought her back early August, do a frozen, she doesn't get regular cycle, do a program frozen cycle, and transfer a 2 PN embryos, grade 2.5, and she had a baby. She had a baby girl, full term, with a history of FSH more than 80. After they, this was so, yes, exactly. It's a day 2. No, they thaw it, they grow it one day, and then they do it later. So it was a frozen on day 1, but transfer on day 2. It was actually a 3-cell embryo. That's it, but 3-cell on day 2. We were afraid the embryo is not going to make it to blastocyst, to freeze it, so we froze it on day 1. And embryologists prefer day 1 versus day 3. Yeah, yeah, yeah. This is, we froze it. The reason to freeze is because of the lining. Why day 1 versus day 5? We were afraid it's not going to make it to day 5. The embryologist likes day 1 more. They feel there's still a lot of water contact. I'm going to decline. Okay. So the next case is about pre-implantation genetic testing for aneuploidy. So this was actually, I think this is, yep, this is the one that literally last month. This is, this is last month's case. 40-year-old, 2 prior miscarriages. She had went to one of the top center, just to tell you that it's not only about the lab. It's more so about being open-minded to change things and look at things all together. She had done 3 retrieval, had PGTA on everything, had a transfer with total of 3 normal embryos, and those resulted, she had 3 retrieval and she had 4 frozen cycle transfer, 1 in each cycle. 2 were negative, 2 were chemical pregnancy. And she had 2 normal remaining embryo. Never had an HSG done. Nobody thought of, like, maybe there is, oh, it's your age, it's your age. Now, had a normal sperm test, etc. So this is the cycle done prior to coming to us. Put her on the pill, gave her 300/150, which, knowing her weight, I don't know if I have it here, I felt that's a lot of drugs, but she had this, and she had a good estrogen rise after she was triggered. She was triggered at more than 20 millimeter, 11 eggs, 10 mature, 8 fertilized. Day 5, she has 2, both normal. Did the first one negative, the second cycle chemical pregnancy. The second cycle last year before coming to us, also a lot of drug. They just changed the microdose. That's where the estrogen makes a difference to check. This is the day of trigger. This is the day after. That's already an indication that she's going to have bad egg whenever the estrogen drop after trigger, which if you don't check, how would you know to learn for next time? She was still triggered more than 20, 15 eggs, 15 mature. Most patients are happy with that. We hate that. We always like to get a mix. Always like to get a mess. Anytime we see that, if somebody doesn't get pregnant, have bad embryo, we go a day before. Even if we trigger her at 17, we go a day before. She had 10 fertilized, but only 3 on day 6, and 1 came back normal. Had the transfer negative. This is the last cycle she did before coming to us. Went up very high to 5,200. That's very high. We very rarely like to see more than 3,000. 29 eggs, but 29 mature, all mature. 8 blasts tested, didn't get result on them. They couldn't get results. They retested them again, and 5 came back normal. Point is, those 5 normal ones were normal from day 1, but now they've been subjected to multiple things. They transferred 2 normal embryo, which is really risky, and I would never recommend it, no matter what. Had a chemical pregnancy. So when she came to see me, she had a very good AFC. AMH was pretty good for her age, 1.26, very good. She's, BMI 25, on the little bit heavier side. I told her, you are making normal embryo. Sure, you are 4 years old. How about you do fresh transfer with the best looking embryo, forget about PG, and anything extra, do genetic testing on that. To try something different, as well as just something doesn't make sense to me. I didn't want to give her 450 unit. We primed her with estrogen. We gave her a total of 300, triggered her at smaller size, knowing how her estrogen drops. So a lot of things are already been done differently here. I did an HSG on her. She never had it done. The left did fill and spill, but she had a hydrosalpinx. Now, is this something that she had at age 15? Or is this something that developed from the multiple retrieval, multiple vaginal manipulation? Who knows? Discuss that. You can do a laparoscopy. You had 3 or 4 tried normal embryos, the impact of hydrosalpinx. I send them the link to the ASRM guideline. I was like, please Google it, decide later. Did the surgery on 123, and this is what she had. Now, some people might argue, well, it did spill. True, but this tube has probably 0 function at this point. She already is doing IVF anyway, and she has this. For me, that's pretty abnormal, but many gynecologists are like, oh, but it's open. Why you want to take it out? Well, because she doesn't want a tube. She wants a baby. And you can see even on the other side, I don't like it when the tube does that motion towards the end. Actually, recently, we have an abstract in ASRM regarding just that. And it did say that she has hydrosalpinx in both. This is pathology confirmed. To diagnose hydro, visual is enough, but this one has a confirmed pathology. So this is her cycle with us. Her estrogen went up only to 2,400. Ignore the 20 because that was an odd one. Most of her follicles were 15, 15, 18, 17, 17, 16, 14. 28 egg, I think. I don't know, it's not clear. 23 mature, 20 fertilized. So with less estrogen, with less drug, with a trigger day earlier, she get 20 embryos. Now she's 40. Now she's almost 41 at the time. 13 were frozen in addition to the 2 that we transferred. Now, you can see those were the ones that were frozen. Now, the results of the PGT, she actually found out that she's pregnant before the PGTA results came back because 2 weeks later. But she's 41. She had 1, 2, 3, 4, 5, maybe mosaic, but 5 normal one. And she got discharged to the OB with a normal. Now, hopefully not, but this could still be an abnormal embryo. And she's going to do the prenatal testing, I think this week or next week, because she's almost 10 plus week. But this is the furthest she ever got in pregnancy. She never got past the chemical pregnancy. The difference was anatomically is this is as good of an embryo probably as the normal one she had prior to coming, but her hydros are out and she had a fresh transfer. In addition, she had those 5 embryos here, and now she has 2 embryos at another place that probably are pretty good still. Now, last, I'd like, this is, I don't know if you guys know who that is. Her name is Elizabeth Carr. She was the first IVF baby in the US. The main people who helped conceive Elizabeth Carr was Dr. Howard Jones, who I was honored to meet him many years ago. He unfortunately passed away. Dr. Zev Rosenwachs, who's my director at Cornell. And the other third main guy was Sohail Moasher, who, for you guys who know Dr. Massad, you know him. He's an Ayyubite, and he's already Jordanian, but he's probably he's very involved academically, and he actually was my mentor in residency. He's one of the reasons I ended up doing that. Dr. Palermo left, but I'd like to thank him for taking the time today. I only asked him about this 2-3 weeks ago after I talked to Dr. Abu Jawde. And we were very fortunate that 2023, the Newsweek just did, they did a survey for more than 3,000 fertility doctors all over the US and all over the world. And, we were fortunate to be ranked by not by patient, this is by expert like you guys, to be ranked as a number 1. Thank you, everybody. And please stop by if you're ever in New York.
Thank you very much. Excellent. Excellent talk. Thank you for you and for
I don't know if you have
for Dr. Palermo that we can't thanks.
I will thank him. I'll give him a hug when I come back.
Sure.
Go ahead.
Your last case, you put unemployed embryo?
I know. I put a fresh transfer, untested.
Untested.
Untested day 5.
Untested.
Day 5, because actually, if you have a minute, let me show you. Sorry, I don't know what happened here. It needs to be saved, cancel. So let me see, just back to Dr. Massad point earlier. This is what the embryologists send us. Let me see if I have any day 3 here. Okay, now this is not, so this one, if you look here on day 3, they give us the percentage to make a blastocyst. So her percent, this is the one who had a baby. This is the one who was 15. plus IVF cycle before coming here. She had, sorry.
Okay.
No. So, so what they do is they give us, they send us a snapshot of this. So this patient had 4% chance of making the blastocyst based on multitude of criteria. They look at the time to division, the first, what time the first division happened. Is it, I'll show you that, for example, this one, this is 1 to 3 cells. So this is one cell that is 2 to 3. We haven't had a single pregnancy with those embryos. That's why they cannot come out with a percentage. So any embryo, if you look today, or you look, it could be an 8 cell, but it's a, they call them duct. If it's an abnormal division like this, we haven't had a single pregnancy or live birth with an early duct, they call it 1 to 3. We had some from 2 to 4 and 5 to 7, etc. But what they tell us is this: percentage of blastocysts, percentage of top blast, and percent of implantation on day 3. And the big variable here, by the way, for this one is the age of the egg. So the fact that somebody's 30 will, the identical embryo, one big component of this was the age of the egg. An identical embryo and a 40 years old is very different than a 12-year-old, sorry, than a 22-year-old. And that's what they tell us here. And that's what help us determine. If she has, somebody have 4 embryo that are in the 40, 50, 60% blast formation, we'll go to day 5. If somebody has, she wants single embryo transfer, and she has 2 that are 40, 50, 60% blast formation, we go to day 5. But if somebody has a better implantation rate here with the slow blast formation, like a low chance of blast formation, let me see if there is another one, then we won't push it. Like, see, like this one here, this one was 4 to 6 abnormal division. They couldn't come up with a percentage. This was day 3.
Day 3, yeah.
That's where we differ with many people. We don't believe that.
I agree with him. Yeah.
We don't. We strongly. That's true. But how about the one that are like so many patients? I actually did a study with one of the fellow a few years ago, looking at patients who had failed day 5, period. Whether it was PGTA tested or not, failed day 5. There were almost 600 patients over a few years that only variable was obviously different lab, but day 3. We had more than 45% live birth was published. We don't have to. We counsel the patient. We do it. We do a 3 cell, and we don't do. We do 4 cell. We do 4 cell and on. We do it. So it's all about talking to the patient, explaining for her. That's why I think one of my first slide, I think we are losing a lot of babies because we are insisting on doing the same thing for everybody. Mm-hmm. Day 5 is good, but not for everybody. The reason, this is old data, 2005, published. 17%. Now, obviously, I think this was a different group of people back then, meaning like they were maybe better ovarian reserve, etc. But let's look at the 43-year-old or even 42. They had 17.5% ongoing pregnancy. So those people with life birth, with heartbeat. So maybe you still lose like 4%, 5%. Let's say 10%. 10% or so are here. Let's say 7.5% miscarry, which I don't think 7.5 because those have a heartbeat. Ongoing pregnancy. Actually, no, sorry. This is pregnancy. So they're 42-year-old. When we were not doing PGT on it, we were having everything we could do is transfer the embryo. We had 17.5%. Let's say 15%. This is at Cornell. Same philosophy. Now, this was around here, the 41 to 42 was 18%. So probably the 42 was more close to the 10%. Normal embryo. This is not live birth. 60% implantation, 60% out of 15, that's like 10%. So you are giving people less babies, but you're giving them maybe less miscarriages. We are 13 doctors at Cornell. There are, and everybody's practice similar, same lab, but slightly differently also. There is 2 or 3 of them that do almost PGTA on everybody. They're actually, if you look, and you can look at pregnancy rate per attending, you look in the age group, their pregnancy rate, their pregnancy rate per transfer is higher but they're not having absolute number. The pregnancy rate, actually, the absolute live birth is actually less than the rest of us. But they have better, like they cycle 100 patients, 50 of them make it to have normal embryo. They have 30 of them. That's 60%, but that's 30 out of the original 100. And that's been, I mean, but that's our philosophy. I completely understand. Many people believe like, you know, no day 5, no baby. That's not the case for everybody, I think. I had a patient, 2013 or 14. She's one of the, the husband has Klinefelter, and she was doing PGTA. He does have sperm, Klinefelter, doing PGTA at Columbia, very good center, excellent. Had done 3 cycles, either embryo don't make it or abnormal. Came to me, I told her, you know, I'll change the protocol, I do this and that, went back because her insurance didn't cover with us, went back to them, did the 4th cycle with our protocol, but the same concept, PGTA, no, nothing. Came to me, she was almost 42 at the time. Dr. Rosenmax presented it at the word, I forgot that one that was in, like, it's like the one that ASRM and Ashri combined. It's not the best of Ashri, it's like one combined. This is like 7-8 years ago. She's 42. We talked to the genetic counselor. He was like, usually Klinefelters, like, you know, the sperm that fertilized is okay. You don't need to do PGTA for us. But she's 42. And I told her, you're 42, you might put 4 embryo back. She got 3 sac. I was like, then you're not going to have a heartbeat in 3 of them. She's 42. 3 sac, she got 3 heartbeat. I was like, you're not going to have a normal one. You're 42. She had 3 PGT, CVS, 3 normal embryo, reduced 1, delivered 2 healthy children at 42. But why she was coming to see us? Because the problem was never her. The problem was her husband. He has very low sperm. His Klinefelter. The problem was him. So obviously she's a better 42-year-old. She's not your average 42-year-old who tried with normal male for a year. Mm-hmm. So it's good, but not for everybody. I don't know how to see this. If
nice cases, very instructive.
All right.
Anyone have any question in the audience?
What are people still awake?
Mm-hmm. We'll close the
sharing.
No, yes.
Oh, you unmuted people, right? I think, or no?
No. They can be unmuted.
You can stop sharing.
Stop share, yes.
Okay.
So any question, don't be ashamed.
حتى بالعربي بيمشي الحال.
بالعربي بيمشي الحال. ايه شكلهم كلكم تفهموا عربي.
اوكي.
لكن نرجع على الكلوميد in cases where there is a poor responder, I think he prefer clomiphene than HMG. Yeah?
Yeah, because also you know the coverage is a big issue also. So you save quite a bit of some money also on that. Mm-hmm. You do less drug, yeah. And
in the case where there is high aneuploidy rate, you think that clomid can give us better?
I don't know if we have data on that. I don't know. I think
the question is for poor responder. What do you, Dr. Masad is with us.
We never do. If there is a committed male partner, the plan is always to do embryos. Never do egg if you have a committed partner. Never. Well, it depends, because if somebody desire multiple children and they understand the risk, we at least like to do 1 to 2 cycle of, assuming they never cycled before, assuming somebody never cycled before, we like to do a cycle, aim to do. I'm not a big fan of PGTA, but I am a big fan in those cases. Somebody who wants to preserve fertility, poor responder or not, you want to know what you're preserving. You want to know they are in Chase Bank, not in Lebanese Bank. You want to know that what you have is a normal embryo. You don't want somebody to tell you, you're 33, you have 4 blastocysts, and none of them are normal. So I like to do PGTA on somebody who wants to preserve fertility, because I don't want her to get pregnant next month with one of those 4 embryos, and then she come back in 3 years and she had 3 embryos and they're all abnormal, and now she's 38, 39. So that's one of the reasons why even 30 years old, after, if you want to do that. But if they do the first cycle, she has crappy embryo, they don't make it to blastocysts, they don't do that. After, you know, we'll do a fresh transfer in that case. So I don't think that it's just the desire of the age of the patient and the desire of her. And some patient will tell you, I would rather not be pregnant and have another miscarriage. After our short, let's do PGTA, no question. And to be honest with you, we subjectively, we see that the more annoying the patient, the more PGTA she's getting, because it's easy to blame it on her. It's very difficult to blame this. No matter how many times you tell her, your chances of a normal embryo are 14%. And she doesn't get pregnant. It's very hard to understand for the patient why it didn't get pregnant. You put an embryo in, why it didn't take? Shouldn't I have rested? What about aspirin? What about Lovenox? What about this and that? So then the more the patient annoying, the more you tell, you know what, do that, because everybody around us is doing it for almost everybody. So that's why, you know, it comes down basically to your question to how old the patient is, what's her family desire is, what's their family desire is, and how do her embryo look from the first cycle.
We have a question from Dr. Shahata from Egypt. He is asking if ovarian torsion affect ovarian reserve. What do you think about?
I think only if in like this patient case, when it's actually too late, kind of it affected her ovary like completely now. But I think if you untorse her early, we have I mean, many patients, the one I can think of is very recent. She had actually at least 3 or 4 torsions. It's my one and only patient who had to go in and put permanent suture with her ovary to the sidewall. And she actually still did plenty of eggs on that side. I think if you catch it early, no. If you catch it late, makes sense that it will. The same thing happened with testicular torsion.
Dr. Rafa, you should.
Yes. Hi.
Hey.
Yes. Hi, Dr. Rony. It's a pleasure to meet you. I'm an Ayubite also. I work here in Beirut. I'm not in an IVF. I just do, routine gynecology. Now we're having an issue of advanced maternal age with a low AMH and a very high FSH. So you just the last case you presented with a sky high FSH. Now it's no more right to say if we see such a patient in the routine setting to tell her there is no chance and you should go for egg donation. So there's always a chance if there is still left some eggs to refer to the right person and do that. Do you agree with me?
I completely agree with you, but 100%. I mean, that patient was told so many times to do egg donation by many different practices. I agree with you, but again, you have to set up the expectation of the patient. For some patient, you tell them 50%, they tell you that's not enough. For my patient, they tell you 2%, they tell them that's fine. Like I want to keep giving, keep trying. But I do agree with you. I mean, the same reason you cannot get a D 100%, you cannot guarantee 0%. I didn't have a chance. Like my patient was relatively young, meaning 36. I have during a pandemic, I had a 40-plus-year-old who actually had similar FSH, and not only she got pregnant and had a baby, she actually has 2 remaining blastocysts with us at age 40. She had an FSH in the 70s to 80, and she was told to do egg donation with one of the other big center, and she's 40+. She made 3 normal embryo. Her baby, I think it's a daughter, as well as she has 2 normal embryo with us. So don't say 100, don't say 0, but you should tell them it's very low or very high.
Thank you.
Of course.
Okay. Any more questions, Ziad? Rony, thank you very much.
Thank you for having me.
Thank you. It was
a pleasure.
Great. We hope
any question you have.
Repeat it.
Yeah, maybe next time we'll have if you guys. I know if there is Tessie here, we can have Dr. Schlegel get his input. Sure, we can do that.
Sure.
So, yeah,
it will be more than.
Yeah. Thanks everybody for taking the time.
He's still working more with the fragmentation, or you are using the Zymoth like what Palermo was saying.
You're asking most of us in the group, we're not a fan of fragmentation. Actually, we never. I mean, sometimes you have to, but we're very skeptic, to say the least. Yeah.
Okay. Thank you all. thank you for attending, and hope to see you next time.
Thank you, everyone.